Don't use the shorthand of saying humans cause climate change, because it's too easy an out for those who don't want to believe. The Earth has changed since it has been changing since it's formed, but human activity is exacerbating that change to a point where nature can no longer accommodate it, and we can no longer adapt. It's happening too fast for us today.
April 26, 1986 marked the worst accident ever in the history of nuclear power. At 1:23, approximately the same time as we are sitting now today, and approximately the same wonderful weather that we have today, it was early in the morning, one of the nuclear reactors exploded and contaminated the huge areas of Ukraine, Belarus, and Russia. And equally horrible was the cover-up of then Soviet governments who endangered its own people and turned hundreds of thousands of citizens into environmental refugees. After 1986, the doors of the former Soviet Union were opened to those who wanted to emigrate. And HIAS has brought over 740,000 Jewish refugees from the former Soviet Union, and over 200,000 from Ukraine and Belarus are currently residing in the greater New York area. Today, 21 years after this horrible tragedy, Chernobyl accident continues to haunt people. But today, 21 years after this horrible tragedy, there is also a hope. This hope came as a collective effort of the leaders of the Russian-speaking community of New York, elected officials, medical community, and grassroots organizations who together are creating a unique project of awareness and early detection of thyroid cancer among the refugees and immigrants from the affected areas of the former Soviet Union currently residing in the tri-state area. This is the project of the very, very deep cooperation between the grassroots organizations, our leaders, and the Russian media. A lot of them, you are present here today. Thank you very much for coming. And now I will switch to Dr. Daniel Igor Branovan, who will be the medical director of this project, please.
The project works on the concept that you cannot ask the whole community to come to a particular center, to a particular hospital, to a particular office. Rather, what we've decided to do is to bring the services to the community, to the people. We know that a very large number of patients are now living in New York metropolitan area, up to perhaps 200,000 people who are affected. What we are going to do is to develop teams of specialists, including ultrasound technicians and doctors, phlebotomists, specialists in radiation surveys, These teams are going to come to the offices of each physician, of the medical centers, of the physicians in the community, to supervise the screening, the examination, and the early detection of thyroid cancer. The program funding covers purchase of ultrasound machines. These are machines that are the best there are. They permit very rapid examination of patients. Something that would take 40 minutes on the regular machine would only take 5 minutes in this units. This is what the initial investment goes to. Thank you so much. In the process of the conference, you will learn more about the disease, how we intend to treat it, and the best way to become involved.
Here we have an opportunity for government to help people who were kept in the dark, who were not told about the potential danger that they were facing. This is a way for New York State to be able to provide the resources to purchase the equipment, to provide the resources to have outreach, to have screening, to try and protect the health of the citizens of New York, the citizens of the former Soviet Union who have chosen New York as their home, to protect them by early diagnosis and hopefully save lives. This is the first of hopefully a several-year project as we build up the funding. This year, I was very happy, along with Alec Krasny and other members of the Assembly, under the leadership of Speaker Silver, to be able to obtain this funding. I want to give a special thanks to Senator Marty Golden, who sat on the Health Committee, Budget Committee, and helped keep a watchful eye on this funding to make sure that it continued to remain in the budget. And it is a pleasure to participate in something that is so life-saving. And I look forward to seeing the wonderful results that come from this grant.
Thank you, Dr. Branovan, for alerting us. And I think that what's happening today is the very particular testament to the ability of Russian-speaking community to have a voice not only in New York State Assembly, but to have a voice in American government at large. I believe that Dr. Branovan and his colleagues have an ability to show to the state and to the country that with the programs like that, we really can do. We can serve the population of New York State much more effectively. Thank you.
Helene, thank you very much, Helene and Alec, for your words. Martin, I wonder if you would say a few things.
Thank you, Dr. Branovan. The Russian-speaking community knew what they were doing when they sent Brooke Krasny to the Assembly, the first Russian-speaking representative in the State Assembly, and working side by side with Aline Weinstein, another great individual and successful legislator, were able to bring and fight to make sure that dollars were delivered to the Russian community and to the communities across the city and state of New York, especially those that have seen firsthand some of the suffering that they witnessed in Belarus and Chernobyl and Russia and the Ukraine, and the hundreds of thousands of people that reside here today, that they will have an opportunity to be screened and to make sure that that thyroid cancer does not make them another statistic. We know what the statistics say. We know the numbers of people that have died. We know the numbers of people that are sick today. And we're there to help the Russian-American community and those across this great city and state. I want to thank the Dr. Branovan. I want to thank Gene Bosch for his commitment and his ability to work with us in directing us to make sure that this funding was delivered so that we can save lives and deliver services to the Russian American community. So I thank my colleagues, I thank you, Doctor, and I thank you all for this conference and bringing and highlighting this terrible, terrible disease and being sure that we address it and address it head on for the future so that we can continue to save lives. Thank you, Doctor.
Project Chernobyl is a fabulous testament to the success of this program because it has given our community, our Russian-speaking refugee and immigrant community, a fine opportunity to learn the value of partnership with government, partnership with community leaders in creating solutions to problems. Many might say, well, the Chernobyl problem is a problem over there, but we live in a global world, and through migration, problems over there are problems here. So again, to our friends in the government, to Dr. Bronovan, and to members of the community, it is a pleasure for Hayas to be part of this important initiative.
Thank you. Before we conclude the press conference, I wanted to give the press an opportunity to ask a few questions within a few minutes that we have. If there anybody has a question, please go ahead. Thank you for this question. You're absolutely right. In no way should this be limited to New Yorkers. We welcome participation of all the people who are affected in the greater New York metropolitan area. The first thing that we will look is to expand these services to the surrounding regions, particularly the region of New Jersey, Pennsylvania, and Connecticut. We will work very closely with the legislature and the political figures from these states to make sure that these services are available to all. Now, to get access to this program, all you really need to remember is the date of the Chernobyl disaster, April 26, 1986, or 4/26/1986. The number that you would call is 1-888-426-1986. The number is already active to accept the names, to start getting a database, and as soon as the funding becomes available, we hope in the summer, this project will move forward.
I want to present with my colleagues a check. It's a big check for $540,000 for the Chernobyl Thyroid Cancer Screening Pilot Project from the state of New York, and you hold on to this until the real one comes.
Thank you, everyone. Please, I invite everyone to take their seats. We have 3 hours of work to do.
April 26, 1986. International Thyroid Center, 1-888-426-1986.
Чорнобиль, Чорнобиль, гірка ти трава, гірке наше людське життя. Покинули хати в Чорнобильськім краї, гине природа, а серце болить і болить.
Thank you. Welcome to the fourth session of the 16th International Conference on Health and Environment. It is my pleasure to introduce to you to moderate this session Dr. Igor Branovin. Dr. Igor Branovin was born in Kaliningrad, USSR, a town in the northwestern portion of the former Soviet Union, formerly known as Königsberg, East Prussia. He immigrated to the United States with his family in 1980. Dr. Branovin is a graduate of Haverford College and Stanford University School of Medicine. He is a specialist in the thyroid surgery and endoscopic sinus surgery and practices at the New York Eye and Ear Infirmary, where he serves as the director of the Thyroid Center. Dr. Branovin has been recognized as one of the best physicians and surgeons in New York and at the United States by physicians and patients in a number of journals and publications. Dr. Branovin has maintained very close ties to the Russian-speaking immigrant community in the United States and abroad, and serves on the boards as the president of half a dozen national and international community organizations. Over the past 6 years, he has devoted himself to advancing the cause of hundreds of thousands immigrants to the United States from regions contaminated during the Chernobyl nuclear accident. Dr. Branovin has organized local and national efforts to improve early diagnosis and treatment of radiation-induced thyroid cancer through early detection and implementation of advanced treatment techniques. Dr. Branovin.
Dr. Durbach, thank you so much for your wonderful presentation. Dear ladies and gentlemen, in the next short but very much information-packed 3 hours, you'll hear some of the world's foremost experts on radiation-induced thyroid cancer, learn the latest information on the significant growth of this aggressive disease in the countries most affected by Chernobyl, and recognize the existence of a large population at risk for developing thyroid cancer in this very city, and the innovative new program, Project Chernobyl, designed to offer efficient, effective, state-of-the-art medical care to this population. I'd like to introduce my co-chair, Dr. Dmitry Shiglik, who will welcome our first lecturer, Dr. Mykola Tronko.
Good afternoon, ladies and gentlemen. It's a pleasure for me to introduce you Director, Institute of Endocrinology and Metabolism of Ukraine, and directors a lot of government program of Chernobyl of Ukraine, Professor Tronko.
As we have already reported on numerous occasions, in 1992, a clinical morphological register has been established by the Institute of Endocrinology and Metabolism, which includes subjects aged from 0 to 18 years at the time of the Chernobyl accident. This register is based on statistical reports of endocrinologists and oncologists from all the 27 regions of Ukraine and on an analysis of medical records of patients who have received surgical or postoperative treatment at the clinic of the Institute. Annually, the number of cancer cases is registered, and incidence rates per 100,000 populations of representatives of different groups is calculated both at the time of the accident and at the moment of surgery. Furthermore, the incidence rates for the 6 regions of Ukraine, which have been more highly contaminated by iodine radionuclides, are being compared. These include Kiev, Chernihiv, Zhytomyr, Rivne, Cherkasy, and regions and city of Kiev, and they are compared to the remaining 21 regions of Ukraine. Now it should be noted that the number of thyroid cancer cases in people who were children and adolescents during the accident is steadily increasing. And in 2005, 412 newly diagnosed cases have been reported. Undoubtedly, the steady increase in thyroid cancer cases may be to some extent associated with a gradual increase in the age of the cohort under study for the period 1986-2005. At the same time, a comparison of the incidence rates for the 6 more highly contaminated regions of Ukraine with the rates of other regions of Ukraine shows the most significant difference between the rates for the last 5 years of the follow-up observations, which is confirmed by a direct relationship between the rise in thyroid cancer incidence and the Chernobyl accident itself up to the present time. Starting from 1992, our clinic has begun to carry out total thyroidectomy. Such volume of operations reduces the risk of local recurrence and is a valuable tool in the hands of an experienced surgeon. An analysis of the results of thyroid cancer treatment has shown that gaining experience in primary or final thyroidectomy performance allowed to achieve a decrease in postoperative specific complications. Dear colleagues, I'm not going to dwell on the main conclusions of my presentations. They stem from what I have already said. I would like to express my sincere gratitude because all those results, all those investigations were obtained jointly with the leading scientific centers in Great Britain, United States of America, Japan, and Germany. I would like to sincerely express my gratitude to all of them. My presentation is just the essence of results achieved during the past 20 years after the Chernobyl accident. Finally, I should say that we've been able to answer some of the questions, but the results that we have received have raised much more questions before us and before the researchers. Thank you very much. It is more than 20 years that I've been working with effects of the Chernobyl accident, and I have seen over 500,000 patients. And in all programs that I have taken part in Russia, in Ukraine, in international IAEA projects and WHO projects, ultrasound method is playing a leading role in primary diagnostics of the thyroid cancer. And if my knowledge can help in achieving progress in this work, I'll be only happy. Next slide. Thyroid cancer makes it necessary to solve a lot of questions, major issues, localize the tumor, determine its location and size, evaluate the degree of the local tumor extent, establish differential diagnosis, perform biopsy under ultrasonic guidance, and evaluate efficiency of various treatments. This presentation is devoted only to one issue: ultrasonic cooperation diagnostics of locally advanced thyroid cancer. In the clinic where I work, from the year 2001 to 2006, we have operated some 460-500 patients annually who have thyroid cancer. The total number of operations amounts to 2,406. The number of patients with thyroid cancer achieved 636 patients. This example shows anatomic section of the cartilage. We can see one of the fragments of this image, and also an ultrasound examination performed in the similar plane. We see very well the upper segment of the right thyroid lobe, lower constrictor of the pharynx, and the lower horn and other anatomical formations. The slide presents a clinical example of T4 thyroid cancer. The tumor has destroyed the medial margin and infiltrated the lower constrictor of the pharynx. Among 220 patients with locally advanced thyroid cancer, lower constrictor cases concerned 11 patients. The sensitivity of the method ranged from 80 to 93%.
На данном слайде представлено.
Here we have pretracheal fat space of the neck and ultrasound method. The second image shows an echogram of the thyroid gland, which was obtained by using the same section. We can clearly see different anatomical formations with the help of the ultrasound image. Here we have clinical observation of a boy of 14 years. He has papillary cancer of thyroid gland. The size of the tumor is 9 millimeters. There is a small deformation of the back surface. According to the ultrasound diagnostics, this tumor spreads within the thyroid gland. Tumor extensions to the pretracheal fat space. The slide shows a fragment of the lower segment of the left thyroid lobe. We see a tumor of 10 to 12 millimeters in size. This tumor destroyed the fascia of the back surface and extended to the fat space.
This is the picture of thyroid cancer incidence before Chernobyl, and you'll notice that it averages about 1 per 100,000. This is now the same data after Chernobyl, 86 to 2005. You notice that the curve is going up, averaging at the end of the past few years approximately 10 per 100,000, so 10-fold increase. Obviously, there are two types of cancers, one arising sporadically, the other as a result of radioactive exposure. I want to point out on this slide the fact that thyroid cancer is extremely rare in children other than as a result of radioactive iodine exposure. And you notice that only 1/2 in 1 million kids was diagnosed with thyroid carcinoma before Chernobyl. Let me show you the data after Chernobyl. These are the graphics of the increase in the incidence of thyroid cancer in the under 18 population, and you see it clearly going up. Now, if we look at the data for patients older than 18, the same trend is evident, but the numbers are greater, as one would expect. This slide, in fact, deserves most of our attention. You now see the increase in thyroid cancer in all the age groups. On the red, you see the increase in the pediatric population, 0 to 15 age, at the time of exposure, with the start coming approximately 4 to 5 years after exposure. If you look at teenagers, the increase started later. Young adults, 19 to 35, is continuing to increase to this time. And if you're looking at the very oldest age group, 46 plus, you'll see that the curve is pointing directly up, which is in fact extremely concerning. This point is important to make as well. This is the dose effect of radiation exposure. And on the very left, you see the increase in thyroid cancer as a result of the minimal radioactive iodine exposure. Whereas on the very right, you see an increase up to 700 in 100,000. So almost 500-fold in patients who unfortunately are susceptible to high-dose radiation. This map shows the distribution of thyroid cancers, a total of almost 1,000 cases. And you'll see that close to Chernobyl, in the region of Gomel and the surrounding regions, the rates are high. Look toward the middle of the screen to Minsk. Those cases are also numerous, most likely not because of exposure, but because of movement of population to the center or to the capital. In children, you see a definite curve of
thyroid cancer manifesting itself 4 to 5 years after exposure, peaking 10 years after exposure, and then coming down. This is an important study to go over with you. A huge number of patients, 740 cases of thyroid cancer, followed for almost 10 years. 1.6 to 1 were female, 92% were exposed to radiation. Papillary thyroid carcinoma accounted for 95% of these cases, with tumors ranging from 2 to 60 millimeters. Over a third small, less than 10 millimeters. So Belarus, as a result of this experience, the standard protocol is total thyroidectomy and bilateral selective neck dissection on pediatric cases. Survival rates continue to be high. However, we need to be aware that this is an extremely aggressive disease, and aggressive management is what maintains these survival rates. Thank you very much.
As we're all painfully aware, the huge amounts of radioactivity released by the Chernobyl nuclear power plant accident exposed millions of innocent people and put them at risk of radiation-associated disease. Subsequent experience has shown that the major health consequence of the accident is thyroid cancer, especially among those who are exposed as children. Let's take a few minutes and review what we know so far. Beginning in 1990, only 4 years after the accident, and a terribly short latency, there was a sharp increase in the number of pediatric thyroid cancers in the 3 neighboring countries of Belarus, Ukraine, and Russia. By 1994, almost 300 cases had accumulated in the 3 most heavily exposed regions. And on this slide, you see the rate of childhood thyroid cancer near Chernobyl in 3 different time periods, before and after the 86 accident. In the Gomel region of Belarus, there was a 200-fold increase in the rate of thyroid cancer in the decades spanning the accident. One of the notable differences between the post-Chernobyl cancers and sporadic pediatric cancer occurring in the West was the huge number of younger children in the former Soviet states. In Belarus and Ukraine, over on the left-hand side of the slide, 426 cases in children under the age of 15 accumulated in the first decade after the accident. In the other countries, a comparable number of cases were accumulated over a much longer period of time from a much larger population. Recent experience has shown that these poorly differentiated cancers continue to occur even as the exposed population ages. And so basically, what we're seeing is childhood cancers occurring in an adult population. For this reason, I think it's reasonable to use childhood thyroid cancer as a model for the Chernobyl experience. So the surgical summary is total and near total thyroidectomy is the preferred operation with central compartment clearance for documented malignancy. The surgeon should also stay out of the lateral neck unless there is clinical disease there that is usually shown on ultrasound. And morbidity can be and should be kept low by multidisciplinary care in high-volume centers by high-volume specialists. However, radioactive iodide is not a clinical predictor of overall survival, so although you have fewer recurrences, they don't live any longer. And I'm going to present a few cautionary slides now from the Mayo Clinic experience, which is really huge. Here you have two treatments, extensive surgery and adjuvant radioactive iodine in 2 different time periods. More surgery decreases the recurrence rate, but radioactive iodine does not decrease recurrent rates at all sites. The previous slides were just local regional recurrence rates in the neck. All sites means usually lung. For inadequate surgery therapy, although it reduces regional relapse, the impact on long-term survival is less clear. And finally, the long-term risk of non-thyroidal malignancy may be a concern. Спасибо за ваше внимание.
Thank you very much, Dr. Conf. Fascinating lecture. Let me invite our next panel, Drs. Winning, Galipta, and Tiwari, to the stage, please.
My topic is listed here, distinctive pathologic features of radiation-induced thyroid cancer. Before I get into that, I think we should be reminded that radiation is not the only etiologic factor associated with papillary carcinoma. It's associated with excess iodine in the diet. Radiation, true, but in the early and mid-20th century, patients were treated for various ailments like acne with external radiation and developed papillary cancer decades later. So radiation, true, and it's dose-dependent, with limited doses associated with the development of papillary cancer 2, 3, 4 decades later. And obviously today we're dealing with high exposure and a shorter lag period and differences in the histopathology. Should also be familiar with the fact that there is a genetic predisposition, as listed here. That is an evolving topic. We're now beginning to understand that papillary cancer, aside from other thyroid cancers like medullary carcinoma, can run in families. And there's also an increased incidence with a variety of syndromes, as listed here: familial adenomatous polyposis, Cowden's disease, and we know that thyroid cancers, particularly papillary cancer, arise in various settings in the thyroid gland, including lymphocytic thyroiditis. So having set that up, I'll now bore you with the details of the pathology of thyroid cancer, because after all, that's what the pathologist, myself, does. And we are the final arbiters in deciding what a given lesion is, whether it's thyroid or not, as being cancer or not. So we subdivide, if you will, the identification of papillary carcinoma into gross pathology, meaning what we look at visually when the surgeon removes it and sends it to the pathology department, and histopathology. So papillary carcinoma is predominantly solid and solitary. It may be multifocal, it may be cystic, and when it metastasizes, it may metastasize as a cystic metastasis and simulate other lesions, particularly in children in the lateral neck, may simulate a branchial cleft anomaly. They may be encapsulated or obviously infiltrative. We may see papillae, and I'll describe what papillae are. We're talking about papillary. You may not understand why we call it a papillary carcinoma. There may be fibrosis and calcification, and we subdivide it according to size. So here are some images. This is a thyroid lobectomy. The tumor obviously occupies the majority of the lobe. It's that white lesion. I don't have a pointer to point it out to you, but it's fairly obvious even if you're not a pathologist. Ultimately, the diagnosis is predicated on the nuclear morphologies, and instead of boring you with these details, I'm just showing to you. They were mentioned earlier by Dr. Tronco, but I want to more fully define them for you because they are unique and they do define the diagnosis of papillary carcinoma. So the nuclei are enlarged. They crowd and overlap, meaning they don't limit themselves to one layer of the epithelium. They have variations in size and shape, and if you think of the moon going from full moon over the course of a month to the next full moon, and all those shapes in between, that's what we're looking for in the nuclear morphology, which you see here. And these have been called orphan Annie nuclei because in the original paper defined by pathologists out of Washington University in St. Louis, these nuclei had the clear appearance of orphan Annie's eyes. But if you ever go back and look at that comic strip, Daddy Warbucks also has clear eyes, but we don't call them Daddy Warbucks nuclei. So it's lucky for orphan Annie. And this is what it looks like on histology, these clear nuclear morphology. So the combination of enlarged nuclei, variations in size and shape, dispersed or clear chromatin, and intranuclear inclusions define the diagnosis of papillary carcinoma. And unlike follicular adenoma and follicular carcinoma, which the cells look identical, and the diagnosis is based on whether that tumor is invasive or not, and we can't identify those features on a fine needle aspiration, if the diagnosis of papillary carcinoma is predicated on nuclear morphology, then a fine needle aspiration, which yields those cells, can be diagnostic for papillary carcinoma. And these are examples of fine needle aspiration of a thyroid lesion showing the features I showed you before that characterize papillary carcinoma, as well as psammoma bodies and papillary architecture. The solid pattern, as I just mentioned, is the most common growth pattern identified in children following the Chernobyl accident, but you should know that there are only a few large series on papillary cancer or on thyroid cancers occurring in children following Chernobyl exposure, and there are some papers that identify other subtypes as being the most common. These was culled from a paper in 1991 written by Dr. Nikiforov and Gnep, as well as the Mayo study. Thank you very much.
Thank you very much. I'd like to thank the organizers for inviting me to speak at this important conference. What I'd like to do is give an overview of the molecular pathogenesis of papillary thyroid cancer, primarily the signal transduction pathways for sporadic PTC, and relate that, when possible, to radiation-induced PTC. Now, the red Ptc fusion genes, okay, at least 15 of them have been recognized so far. The red PTC1 is the one that's most commonly associated with sporadic PTC, and the red PTC3 fusion gene is the one that's most often associated with the radiation-induced, such as in the Chernobyl experience. Red PTC mutations occur in about 30% of the sporadic and radiation-induced mutations, and what happens is that there's another chimeric gene, the NTRK1, which is found in about 10% of the sporadic cases of PTC and about 3% of the Chernobyl events. Now, turning to the progression, that's the changes in cell cycle, that's the changes in growth factors, and changes in interaction with the extracellular matrix. Here is the cell cycle. There are 4 different phases. The G1 phase, where, for example, the thyroid follicular cell will be making thyroxine and secreting it. Synthesis is when you have, in the synthesis phase, you have the replication of DNA. The gap 1, you're getting ready for mitosis. Chromatin is then being packaged, and in the mitotic event, you do have the actual mitosis itself. The transition from phase to phase is regulated very tightly by cyclin molecules with CDK, the cyclin-dependent kinase heterodimers. This is another study that Dr. Tronco had participated in. This shows the hierarchical clustering of adenoma, of post-Chernobyl thyroid cancers, and sporadic cancers. You could see that, for example, here's a cluster of genes that are upregulated, these are downregulated. Sure enough, these are the adenomas over here, and these are the PTC. But what happens is, within the PTC, the computer-directed clustering gave 2 samples, okay? And both of these have the Chernobyl and the sporadic cancers. So in fact, the conclusion of this study was that there is no gene signature separating sporadic and post-Chernobyl PTCs, although there is a signature demonstrated for the adenomas. The conclusion was also that the study of the Chernobyl PTCs would be a very useful source for studying natural papillary carcinomas. I would go just the other way and say the basic science and translational research of sporadic PTC is useful for the diagnosis, prognosis, and treatment of post-Chernobyl PTC patients. So in summary, PTC is characterized by distinct mutations in molecules involved in signal transduction. All of the genes are involved in cell cycle regulation, cell adhesion, and response to growth factors. The microarray technology is a useful discovery tool for identification of molecular alterations, diagnosis, prognosis, subclassifications of cancers, and also for the identification of therapeutic targets for PTC. And the molecular analysis of sporadic PTC should be relevant to the Chernobyl-related disease. Thank you very much.
Thank you very much. Good afternoon, everyone, and it's a great opportunity for me to present to you some of our thoughts on the identification of estrogen receptor in papillary thyroid cancer and its implication some of the future treatments, and I'll probably touch on some of the clinical trials that are going on. And this is, I think it's an important way of looking at thyroid cancer in terms of what we know of its epidemiology, which has been discussed, and how it sort of interrelates with the biochemical as well as the molecular data. So if by way of introduction, if you look at thyroid proliferative disease that affects almost about 200 million people worldwide, every year in the United States we have about a good number of thyroid proliferative disease diagnosed. But the most important thing that one sees is that was discussed over here, and again this is for thyroid proliferative disease and not thyroid cancer, is about 10 to 100,000 women are diagnosed and which is twice as that as in men, which is about 4. So, and again, several studies suggest that women of childbearing age are at high risk of non-medullary thyroid cancer, prompting us for an hypothesis to formulate, to look at in the laboratory is this observed gender bias in the distribution of the thyroid neoplasms related to some kind of tissue-specific estrogenic activity. And when we talk about estrogen now, most of us know that it is a female hormone, and there are many different effects of the hormone. But if you characterize the effect, you can probably put that into 3 different categories. Estrogen manifests its biological effects as in thyroid proliferative disease by generating active estrogen metabolites, modulates the signal transduction pathway that would induce proliferation, and a new concept that has emerged as that it can also induce neovasculogenesis. Now, vasculogenesis is a very important part, as thyroid is a very important, very vascularized tissue, and obviously if estrogen has a role, this could possibly explain the epidemiological observations that we've been seeing in terms of incidences more prevalent in women than in men. Obviously, to look for these effects, we must look at whether the estrogen-mediated processes are present or not. The first one that we looked at is the estrogen metabolism. And estrogen metabolism is a biochemical event that takes place in the target tissue by which actually estradiol is converted into estrone, which is by an enzyme called 17-beta dehydrogenase. And then 2 important properties that come up is basically how estrone is converted into its hydroxylated and converted into 2 properties. So one of our aims was to look at whether really in the breast cancer cells, thyroid cancer cells can metabolize estradiol. In fact, they can very actively metabolize estradiol into estrone as well as into 2 and 16-alpha hydroxy estrone products. So thyroid cancer cells have the enzymes that can metabolize estradiol and can produce the products that we were looking at. Now, we looked at the proliferative activity of estradiol on these papillary cancer cells, and what we saw was that if you starve the cells, so they were estrogen sensitive, so if you took away estradiol from the media, the growth rate dropped and the growth rate increased when you added estradiol. When you added an anti-estrogenic compound, it inhibited its growth. This was on a time scale of 24 and 48 hours, but surprisingly, there was nothing that was happening to the estrogen receptor per se, as it remained unchanged. So estrogen receptor per se may not be the one that is modulating the activity of estradiol, but it is possible that the other estradiol metabolism as well as the signal transduction pathway and its effect on neovasculogenesis may be pertinent and important in thyroid cancer and thyroid proliferative disease. A very important point that we have just started in our group, but it is worth mentioning, is the estradiol's role of mobilizing circulating stem cells, the estrogen, the endothelial progenitor cells that are key for vasculogenesis. And if estradiol can mobilize these at the site of the tumor and can induce neovasculogenesis, that would be a very important criteria for the explaining the differential thyroid cancer prevalence that we see in women than in men. Obviously, this is something that is prevalent in the stem cell biology of cardiac muscle regeneration, but we see it important in terms of thyroid proliferative diseases as well. I would like to summarize the results, saying that PTC demonstrates increased sensitivity. It expresses the estrogen receptor. An anti-estrogen DIM that is present in diets has anti-proliferative activity and can be partitioned in biological fluids. And we feel that a dietary anti-estrogen can, using all the three different specific properties of estradiol, can now be used as a preventive agent. I thank you again for the opportunity, with acknowledgements to my colleagues at NYEE and at NYMC. Thank you.
Well, how do we define thyroid cancer? It is defined as invasive cancer that refers to any extension of the disease outside of the thyroid gland to involve surrounding structures, as well as extension of disease outside of an involved lymph node to involve the surrounding structures that are adjacent to it. The vast majority of patients who have this disease have disease confined to the gland and to the regional nodes. And if one seeks to find out what the prevalence of extrathyroidal or extracapsular extension from a lymph node, the series that are presented here represent fairly large series that rate somewhere in the range of 8 to 10%. However, as you've heard during this presentation, the population of patients that we are discussing this afternoon have a much higher level of aggressive disease. And I would say that probably in the United States, with a much higher incidence of early disease being detected, I would say that most current studies or a series of thyroid cancer patients would show a lesser incidence of invasive disease just by virtue of the sheer numbers of early thyroid cancers that are being detected. Well, what structures are at risk? There are a significant number of structures, both within the visceral central compartment, as well as any structure in proximity to a lymph node that may be at risk in levels 2, 3, 4, and 5. And those are listed here in this slide. And if you look at some of the larger series, one from the Mayo Clinic, as well as the series on the right, that probably from the audience are going to be very difficult to actually see what these numbers reflect. But this breaks down the various structures that indeed are involved. And a series from Japan looked at, again, what structures are involved by invasive thyroid cancer. And these are the structures and the incidence in which they were reported. And then there are certain cases of very aggressive disease in which there is extensive involvement of virtually everything in the central compartment, as shown in this particular slide. Well, what is our treatment for laryngotracheal invasion? The resectability is determined by the involvement, both the depth, the length, and the involvement of associated structures. The therapy for this can range from just a shave resection for those tumors that have superficial invasion. It may include a tracheotomy as a method for just obtaining airway intervention for those patients who are deemed unresectable. Or it may include a sleeve resection, a window resection, a partial laryngopharyngectomy, or in the most extreme cases, a total laryngopharyngosophageectomy with reconstruction. Methods for reconstructing the esophagus are a separate discussion than what I have time to talk about this afternoon. And finally, there are a number of different factors that impact on the prognosis of invasive thyroid cancer that are well chronicled in the literature, and time does not allow reviewing all of these. So in conclusion, anywhere from 8 up to certain series, as many as 20% of selected populations of patients will have extrathyroidal extension. Patients with symptoms require further evaluation through morphologic evaluation, and it's imperative that surgeons treating this disease must have a high index of suspicion.
patients with vocal cord paralysis and an infiltrated recurrent laryngeal nerve should have their nerve sacrificed as long as there is documented cancer, which is imperative for patients who present with a tumor and vocal cord paralysis to document whether you have indeed cancer, because there are select situations where vocal cord paralysis can occur in the benign setting, and removal of a benign tumor may lead to resolution of that process. And finally, the surgeon must be prepared to deal with intraoperative findings of invasive disease, and the removal of all disease from the air digestive tract should be accomplished at the outset, at the initial operation. And finally, there is a role for external beam radiation in addition to radioactive iodine for this particular population. Well, thank you very much.
Thank you so much, Mark. I neglected to introduce you fully. You just heard Dr. Mark Erkin, who's the Chief of Division of Head and Neck Surgical Oncology and Co-Director of Institute of Head and Neck and Thyroid Carcinoma, Beth Israel Medical Center.
In a most recent, pretty extensive review of 15,000 cases from multiple centers in Italy of thyroidectomy, they found that during benign disease, there's only 1% incidence of recurrent laryngeal nerve paralysis, permanent paralysis, but in disease of malignant thyroid cancer, it's actually significantly more, and up to 5%, which is a very, very high rate. But immediate repair has a lot of benefits. For one, the patient only needs to undergo one operation. You avoid operating in the surgical field for future reinnervation if that's necessary. Reinnervation itself is actually more successful the earlier you do it in time relationship to the sacrifice of that nerve, so your results will actually be better. There's minimized morbidity due to the vocal fold paralysis and glottal insufficiency if you can rehabilitate the patient immediately. There's no foreign implant necessarily, and if the reinnervation does fail, you can always go ahead and do a laryngoplasty and still rehabilitate the patient with a second stage procedure. One thing we need to know to do this surgery is the technique of how to do it, and also to make sure that there is an available nerve of the recurrent laryngeal nerve you can anastomose to, and also the donor nerve. You can actually use the ipsilateral or contralateral ansa cervicalis. An excellent treatise on the anatomy of the nerve was done by Chetri in 1997, and I won't go over it completely, but the important thing is that this is the ansa here, coming down in a superior limb, and then the posterior limb here, and then this is the summit loop, which we generally use to identify the nerve underneath the omohyoid muscle. And it's relatively constant there, but there is a certain percentage where this loop can be anywhere from the omohyoid to the clavicle. Generally, that being the case, you need to also be able to identify the nerve as it enters the strap muscles, because this is quite constant at 2 centimeters over the clavicle. So this is a surgical view of a cadaver, this is the hypoglossal nerve with the ansa coming off of it, the omohyoid and the SEM reflected. Okay, with retraction of the omohyoid, you can see there that you have the loop of the ansa cervicalis right in its position that you would expect. And here is the innervation on the lateral aspect of the strap muscles with the branch to the sternothyroid and the sternohyoid. The recurrent laryngeal nerve actually is quite close to the ansa cervicalis. It's actually found to be only about 1 centimeter away, so even though it's out of your surgical field, it is very close by. With the head in extremis, you can make this anastomosis with minimal to no tension, as you can see here. Okay, and more importantly, in terms of the aggressive cancer that we're speaking about today, when there is no distal recurrent laryngeal nerve available, if you split the inferior constrictors over the inferior horn of the thyroid cartilage, you will be able to then access that nerve if you retract the cartilage anteriorly, and here it is, just underneath that cartilage there. And that is usually pristine nerve that is not affected at all by the cancer. So if you don't have the nerve in your field, you can actually find that nerve nearly all the time. And then to make your anastomosis, you just remove the horn of the thyroid cartilage, and you have a nice long nerve there to anastomose to. And again, with the head turned the opposite way, in extremis, you can have an easy tension-free anastomosis. So there is a delay in rehabilitation. I'm almost done with the the voice beginning to return about 2 months. So what we do to bridge that gap is actually inject the patient with Symetra, which lasts about 4 months, and this can be done within days after the surgery, as soon as the patient is up to it. It's done transcartilaginous, this in the office, looking with the laryngoscope. We can actually inject straight through the neck. It's a relatively simple, painless procedure that can take between 5 and 10 minutes. And then what happens is that this vocal fold here will actually bulge up with Symetra, which due to time constraints I won't show you that. You just have to take my word on it. And it'll medialize the vocal fold. Within just a few days of the surgery, they'll get their voice back. And as that Symetra wears away, the reinnervation will come back, and they won't need a secondary procedure. So in conclusion, we know reinnervation works. The distal recurrent laryngeal nerve can almost always be exposed by the techniques we talked about today. Immediate repair of the recurrent laryngeal nerve should be planned for in all operations where we know that there is going to be a cancer resection of thyroid surgery and a possible resection of the recurrent laryngeal nerve. So essentially, if we think about it and we know how to do it, and we employ this recurrent laryngeal nerve anastomosis at the primary time of the surgery and the Symetra, we can minimize the morbidity of these patients to the fact that they only have a few days to a few weeks of disability due to this recurrent laryngeal nerve injury.
I'd like to talk today about 2 points. The first is that the importance of preoperative workup and preoperative laryngeal exam, the technique of intraoperative monitoring, and start today with 2 observations that Chernobyl, although 20 years ago, really is a disease that occurs and occupies surgeons currently. It is a problem in the present because children who had a short latency to the onset of malignancy are now adults and experiencing their cervical nodal recurrences. And it's also a disease of adults. That is, the adults that were exposed at the time of the accident now have an increasing slope of increasing incidence of thyroid cancers in a way analogous to the data at Hiroshima and Nagasaki as a result of Japanese exposure. And also that the problems infiltrate into today because of the immigrant populations that require aggressive diagnostic scrutiny and aggressive treatment, which has been in large tackled with the initiative that Dr. Branovan has piloted in terms of aggressive surveillance of Chernobyl populations in the New York area. So basically, this is really, I see Chernobyl exposure, radiation-induced malignancy as an adult problem, and that it is an adult problem with commonly invasive disease. And so Dr. Erkin's presentations looking at the different ways that surgeons need to extend the standard thyroidectomy for treatment of cancer that is extending out of the thyroid gland is more important to keep in mind in patients who have thyroid cancer radiation-induced. This is data from last year's conference, and I think this is a very important slide from Belarus that shows the increasing slope of incidence of thyroid cancer in adults. This is very similar to the data in Hiroshima and Nagasaki. Although the disaster was 20 years ago, the incidence of adult-onset thyroid cancers are increasing. There are several reports that document that the adults who were brought in for the cleanup, called liquidators, have increased incidence of thyroid malignancy here in 115 out of 100,000 patients. And these subgroups of adults exposed at Chernobyl can be broken up into several different subgroups. They can be broken up into liquidators, those from evacuated high contamination areas, and those from inhabitants of more mildly contaminated regions. And data at from the UN can segregate these adult populations into specific radiation strata or regions of radiation exposure for liquidators, evacuees, and residents of mildly contaminated regions. And so basically Chernobyl is a disease of adults, and it is a disease now, my second point, that is most commonly characterized by invasive disease. Here you have data from Ukraine showing that extrathyroidal disease, that is cancer at presentation that extends outside of the thyroid gland, is nearly double in adults exposed to Chernobyl as compared with Group A, which is a control non-radiated group. And so, at least in the Ukraine data, the rate of extrathyroidal disease at presentation is nearly double. This is actually true both of adults and children at Chernobyl. The rate of extrathyroidal disease from Chernobyl irradiated induced disease is substantially higher than in non-irradiated controlled populations. And this has tremendous surgical importance for the surgeon and tremendous importance for the patient. There are numerous references emphasizing the higher aggression of radiation-induced thyroid cancer. And so now how can we look at thyroid surgery given this nature of adult disease and more commonly invasive disease? I'll talk about the importance of preoperative laryngeal exam and a consideration for neural monitoring in these patients. And wedded with neural monitoring is pre-op and post-operative laryngeal exam in all patients. So prognosis, finally. We know that I'll end with this, that visual examination of the nerve at the end of lobectomy is insufficient to determine whether that nerve has been injured. We know studies suggest that probably between 10 and 14% of nerves injured are visually identified as being injured by the surgeon. And so we know, however, that if the EMG signal changes at the end of lobectomy, we have a tremendously high negative predictive value. And so when the EMG signal is good at the end of surgery, we have nearly zero rate of temporary paralysis, whereas if the EMG signal changes during surgery, that is, the test for nerve paralysis is positive, that 3/4 of the patients have paralysis. So this is very important. I'll end that if the EMG signal changes during surgery, you know that that nerve has very likely been injured. You can explore the nerve to identify the site of presumptive injury, and you can delay surgery on the second side. This is an important algorithm to avoid bilateral vocal cord paralysis. Thank you very much for your attention.
We would like to request Mr. Krzyzewski, the chargé d'affaires for the permanent mission of Ukraine, to make the closing statement.
Thank you very much, Dr. Durbak. Madam Chair, ladies and gentlemen, I think you will all agree with me that the conference was extremely useful and informative. Our 2 days deliberations have been a real stepping stone in advancing the issues of health and environment. To have a discussion between diplomats, the leading experts in the areas of environment and health at this forum was a unique opportunity. I have personally been inspired by the commitment of the knowledgeable participants during our deliberations. As for Ukraine, it is very important that every year, among other issues, we are addressing science-based evidence of Chernobyl's technical, physical, and psychological ramifications. Madam Chair, I would like to use this opportunity to express my sincere thanks to all delegates and speakers at the conference for their valuable contributions. I would also like to warmly thank all member states that have co-sponsored this event and praise them for dedication to the successful work of the forum. Of course, our particular thanks go to the World Information Transfer, its president, Dr. Christine Durbak. We are looking forward to continue fruitful cooperation with you in the next year as well. Finally, let me wish you all the best in your future endeavors. Okay.
Thank you very much, Mr. Krzyzewski, for your wonderful closing remarks. And now I would like to ask Dr. Igor Branovin for his closing remarks.
Thank you so much, Christine. Thank you, Dr. Korzeniewski. I think you've all been remarkably patient and attentive through a very intense 3 hours of session. I want to thank you all for coming. I know that the work that we are doing is important to the large population in this city and in this country, and I invite all of you who are interested in becoming part of Project Chernobyl to please join us, and together we're going to serve this community to our best abilities. Thank you so much. See you next year.
I would like to begin by thanking Her Excellency Mrs. Mirjana Modaneo, Permanent Representative of the Government of Croatia, Mr. Viktor Krzyzewski, Charge d'Affaires of the Permanent Mission of Ukraine, Ambassador Jiro Kudera of the Permanent Mission of Japan, Mr. Mohammed Ali Sukhar, Deputy Permanent Representative of the Republic of Bangladesh, the Permanent Mission of Philippines, for their co-sponsorship of our 16th Conference on Health and Environment, Global Partners for Global Solutions. The support of the permanent missions of Azerbaijan, Georgia, Haiti, Republic of Slovenia, and Uganda. I would also like to thank UNDP, UNEP, UNICEF, and WHO for their collaboration, and DESA, NGOS, Rotary International, and Stakeholder Forum for their support. Finally, I'd like to thank all of our prestigious speakers and moderators, Dr. Sophie Bock and Dr. Igor Branovin, for the valuable knowledge and insights, all of our board members and board of advisors, our interns, volunteers, and all those who made this conference possible. At the end of the day, I would like to link together what I believe was a wonderful conference. I'm not just praising myself, but everybody concerned. It is important to come back to the issue of political will, as we have heard during both of our lunches and some of our speakers, and as you all heard during the video and press conference held with Dr. Branovin before the beginning of this session. We need to realize that what we hear has a powerful role in our actions, and that we need to make sure that what we hear has a scientific basis. To quote Charles Darwin, ignorance more frequently begets confidence than does knowledge. It is those that know little, not those who know much, who so positively assert that this or that problem will never be solved by science. You have heard during all the sessions that science is a wonderful instigator for solutions of many problems, even those that were considered unsolvable just a few years ago. For change to take place, we need to move from static behavior to social change. And that can only happen if our communication and developmental interventions incorporate the health needs of all of our populations. As we heard, the sarcophagus was supposed to be completed in 2005, and now it is 2008. Old problems will continue as long as there is no political will to change, whether it is building a sarcophagus, changing the approach of thyroid cancer treatment, or accepting the need to change old perceptions and behavior that is contradictory to scientific findings. I hope that what you heard yesterday and today will continue to motivate you to change what needs to be changed for the better, for a healthier world, for future generations. Thank you. The meeting is adjourned.